Yeah, welcome, dear audience, and Jose. I'm very pleased to present you my speech about the endoscopic procedure of facet joint and SI joint. I'm Mr. Ibrahim from Munich, a pain specialist, orthopedic and physiatrist, and I want to show you procedures which I also developed in 2015, and I give you my follow-up, my studies, a 2 years follow-up in 2018-19. First of all, the background of SI joint. You know the importance for chronic back pain. We see in Europe by now the prevalence of 16 to 30%, and you can just keep in mind for patient with virgin back, every third patient is coming to your in or outpatient service, and after surgical spondylitis and fusion with this sacral part, we have every second patient who is coming with chronic back pain in SI joint problems. So what is the SI joint pain arthropathy by definition? It's called by the European Pain Society. So we have 4 important topics: the clinical localized pain points in SI joint. You should realize the specific clinical tests. We call this provocation tests, which shows you when you're just doing 3 tests, a positive sign, then you should be nearly clear, more than 90%, that you have a SI joint problem. And of course, you should, in relation to the radiographic diagnostic, to see if there are other problems, for example, disc problems or spinal stenosis. So that's why you should do a radiological testing. And of course, you should do a precise, specific local block. So for the etiology situation, we have intra-articular or extra-articular reasons. You see on the right slide, the slide picture shows you a clear white area, which is important for edema, specific for arthropathy by rheumatic diseases, which the more you do, you're just working with SI joint, you will see much patient with having SI joint rheumatic areas, for example, the morbus Bechterew. And we should keep in mind other reasons, what I told you before, by lumbar or lumbosacral fusions, spondylolisthesis, hip replacements. Keep in mind by patient having hip replacements in the surgical part, it could be have an irritation to the SI joint. Different length differences gives you a joint instability. So all these could be reasons for this chronic arthropathy. The clinical signs are, we call them a chameleon, different areas of this typical signs of SI joint, which is not only the part which you see here on the picture on the typical area of the SI joint. It could have a radiation to the leg, like a nerve root, which is not a nerve root. And it could also go down to the foot, just the abdominal or foot problems are showing you a part or the different areas where SI joint problems could be presented. For the clinical provocation tests, which is not well known, you have different parts. We call this the typical signs of distraction, of compression tests, or this tight thrust test with a leg push on the SI joint, a Gillette test, a Genzelin test, and you should know just 3 different tests to make a clear, nearly 85% of sensitivity and specificity to this SI joint problem. The radiographic evidences, first of all, you should know that there is no correlation between radiographic diagnostic and positive SI joint interventions, or making clear there's also no sensitive MRI to evaluate an SI joint arthropathy. That means that you have most of the cases patient having SI joint problem, but you can't see any MRI joint, MRI pictures been showing you inflammatory or so on. And on the other side, if you have a big arthropathy like arthrosis on this SI joint, doesn't mean you have a pain patient. So that makes the situation not easy, but you should do always radiographic evidences or radiographic pictures to make sure there are other reasons what I told you by spinal stenosis or disc problems. And not at the end, the diagnostic block, so you make sure, usually in my outpatient service, I do an SI joint block itself, a facet joint block of itself, and both together. And if I see the pain relief after the diagnostic of more than 50%, then I starting later on with this procedure. The nerve network of the facet in SI joint, what you should keep in mind here in this left picture, shows you that there are many different areas of pain. For example, for the crista, you should know crista problems in general are not crista problems itself. It could be muscle problems, it could be ligament problems, but it could also be problems on the upper facet joint of the lumbar space from L1 to L3, for example. On the other side, you should know about the big ligament structures. There could be also problems of the os coccygeus, a chronic part, so another problem of this area, but we should keep in mind the chronic SI joint innervation, which is coming from the posterior part from L4 to S1. But we will keep deeper when I show you the other structures of the capsular area and also of the ligament area, which gives you a very overview about the whole tissue situation. Keep in mind that all these sacroiliac, posterior longitudinal or sacrointerosseous ligaments are also having specific sensories. So that means we have not only ligament structures, we have pain perceptions inside these ligament structures, which shows you also pain areas and pain points for the SI joint. So if you take this sacrum for itself, isolated from the cadaver, you see that you have three different foramen on SI, S1, S2 and S3. And on the left part, which has been well known since 2016 by a study of my friend Miss Agur from Canada, you see this posterior sacral network, which is a specific network for pain perceptions and also pressure Golgi systems. So it gives you a fully information about pain standing in the area in 4 dimensions, and it gives you also the main area for pain perception for treating in pain. So these are the areas well known by Mr. Roberts and Ms. Agur, from the area where the pain nerves coming out of this area of the foramen. It's in L5 and it goes up to L4 also. That's why we have to do specific radiofrequency, for example, ablation from L4-5 till S3. And there is no variation. So there is no variation of the nerve roots. So they are always coming. What you see, for example, one on L5, we have an S1, 2, and it goes down to S2 and SS3. So keep in mind, not always for the radiofrequency treatment, that where the nerves are coming out, and you see the percentage of this variation well known, well presented. And if you look at also on the lateral view, you see how from S1, for example, 3 different nerves are coming out, going to the posterior sacral network. From S2, 2 nerves going out, and from S3, 1 nerve is coming out. In very rare cases from S4, but we don't treat this S4 area. But also to see there is a connection to L5, and especially if patient has a facet joint degeneration, you should also make it in one treatment, also the pain treatment to L4-5 area. So these are the indications for facet and sacral joint interventions. Of course, we're using it also in rheumatic arthritis. Patient with having mechanical problems, depends, a question mark, does it always work? You should keep this in mind. We have some other hypermobilities, and of course contraindication, as you should know when there are other reasons, not as for the SI joint treatment. So the pain perception is the medial lateral branches, medial for the facet joint, lateral branches for the SI joint. You have this instability and hypomobility of the SI joint, which is very joint for with big ligament structures inside. So there's very rare instability reasons. And you have, of course, the capsular synovial inflammatory reasons, and you have the ligament and the myofascial sensory areas of this area. So much work to do when we are talking about the reasons of the pain perception of the SI joint. So then you have the treatment. It's well known by radiofrequency, more than 40 years, with a cooled radiofrequency with more than 40 to 50 or 60 degrees. You have the heating radiofrequency by 90 degrees, and of course you have some specific mechanism by simplicity cannulas, for example. We have this stabilization for hypomobility by patients after accident or after injuries on the SI joint. You have this, of course, non-surgical part for multimodal with specific braces, for example, physical, manual therapy, chiropractic procedures. And you have, at the end, the endoscopic facet joint treatment, which I will show you in detail now. But before this, you know that the radiofrequency treatment, the heating of the structures of the nerve root, ramus medialis from the facet joint, ramus lateralis from the sacroiliacal joint. There are just rare studies about 3 months to 1 year, and these are the results which I can also see in practice, that in this time you have this result. So I use this procedure to keep in mind for patient having a high comorbidity, or patient who are not able to do any Foley anesthetic for endoscopic procedure, and for patients who are not allowed to doing any kind of Foley anesthetic. So it's still in my pain system. The endoscopic procedure, which I create in 2015, it's well known to the facet joint since 2012. I developed this procedure in 2015, and we are doing now more than 1,000 cases till today. So much work, much experience, and I want to show you the surgical technology in detail now by this clear endoscopic procedure, which I show you now in detail. So these are the literature of the facet joint from a friend of mine in Cologne by Igressa, Siddiqui, and from Scott, and we keep on talking about this in prone position as a patient in my inpatient service. We use this in Foley anesthetic, but you can also do this in local anesthetic, and you must show this under X-ray control, a clear position patient should be presented. So if you know from the picture I showed you before where are which structures, so you must keep in mind where are the specific nerve roots and where are the posterosacral networks. That means especially on SY you should do a lot of coagulation around this area to get the fully area of the PSN. So this is how I work. So important is if you're working on one side, it must be a clear, flexible wrist in your hand. Otherwise, you can't do more than 2 cases at one day. That's why you should know it's under X-ray control. And after I made the right approach position, I don't need the X-ray anymore. And then I look directly on the endoscopic way under visualization. And what you can see here is the first structure. So you see You see at the beginning the transversus process, for example, on the facet joints. You see then the specific capsular structures of the joint. Of course, in many cases you see scars because of surgical being done before, and you can take this by microsurgical away, osteophytes, for example, capsular structures, and you can do this specific monopolar or bipolar denervation and vaporization straight to the joint and straight to the nerve pain perceptions. Here you see now the typical way in about, I make it fast, in about 3 minutes, how we work on the facet joint. This is a patient who had on L5-1 a disc prosthesis, so the facet joint of L5 area was the problem, not only, but one of the problems. And the first step when you put the approach directly to the L5 transversus process, so you must have contact directly to the bone, and then you can go through the multifidus muscle. And then what I do here clearly is a monopolar, taking all the soft tissue areas away. So the first step is to make a muscle release to the multifidus, and then you go step by step down over the soft tissue area down to the facet joint. So you see here this area. So if you look now, this is the medial part is in 6 o'clock, the lateral part is in 12 o'clock, the cranial part is in 9 o'clock, and the caudal part is in 3 o'clock. So you can work still step by step and take your time. You should have the blood pressure under 100 systolic. You should have a water fluid more than 80%. Jetzt hat er Stopp gemacht. Oh, more than 80%. And so then you can go step by step down to the area. Müssen wir mal gucken, ob wir das nochmal hinbekommen. So here we are. Now I go a little bit back. So you see now in this area the joint. You see the facet joint. So you see the capsula, the part of the joint. And what I do is putting an osteophyte away. We call this a partial arthrectomy. And if I took this away, I can then go further, step by step, to take it clearly under control. And if we have done this, then you see you can look inside the facet joint itself. It is not, be careful in this case, is specific by patient having a disc prosthesis that you don't starting hypermobility of the joint itself. And after you have done this, you're starting this monopolar around the ligament and around these structures of the facet joint down to the ramus medialis of the nervus, doing a neurotomy. So this is how I treat this. So all the patients which are doing the SI joint treatment, I starting with L4-5. As I showed you the pain perception, we're going to L5-S1. Starting with S1 foramen, should be also looking to both sides to have a clear orientation, and you go to S2 and S3. So you're doing 5 areas similar to the facet. You're doing it the similar part to the SI joint. So you make a release, in this case, of course, in the area of the gluteal muscle. You go down to the foramen, and you are just taking away the capsular area, and you're going down, what you see here, taking away ligament structures, making a clear opening and approach, making the neurotomy, and then you'll be down to the foramen, what you can see here step by step by the microsurgical excision of the capsula, of the ligament structures, and you starting the neurotomy of the nerve area. So there's by now only my study in Europe, but I hope we are having furthermore other interesting studies about the SI joint. So we put this patient, the first 30 cases, we put in a clear cohortic study with patient having more than 6 months this conservative treatment. We make a positive block. This is a very important part. We, of course, have done MRI pictures before, and the clinical shows a clear positive provocation tests, but there were no patient with rheumatic disease or neuropathic pain, and no patient having a surgery as a SI joint fusion before. Yeah, this was in 2018. By now we've done more than 1,000 cases, but these were the first interesting studies with this patient. You see we have only one patient having, from the 30 cases, a virgin back, so no surgical part. The other 29 had a nucleotomy, a decompression, a fusion of the lumbar spine, and 6 of them have also spinal cord stimulation by high frequency. So these were the results for 2 years. So we're starting from the pain situation by 7.23 at the beginning. We have a significant changing till 6 months, and still a significant part after 1 year with 1.27. So it's a very high reduction of the pain situation, and still after 2 years we have the way of 2.882 pain relief. So it's a much more pain relief. This is the average pain to look for the developing after 2 years. So it's a significant changing in the pain area after 24 months. So a great result. And regarding to the pain, also the flexibility of the patient measured by ODI, you see, and always you have to see if a patient had more than 40% of the ODI score. That means a very severe hypomobility, and we change this more than 50% to much more better mobility of the pain. For the patients, it's always important that not always the pain is better, the whole flexibility is more important for the patient, and you know if the SI joint pain is much better, then also the flexibility will change dramatically. So in this endoscopic procedure, also to talk about complications, and when we start at the beginning, we need more than 2 hours for this treatment, and now we need about 30 minutes. Actually, we had now changing the blood pressure. That's why we had bleedings at the beginning, and of course of the pressure of the superficial peripheral nerve, we had a meningia paresthetica. But for the take-home message, by clear indications and clear patient selection, following the landmarks, we will do this also in workshops that you must have contact to the bone structures. If you don't have contact, you should start again. It's an easy and fast performed treatment in pain therapy with good long-term results in 2 years. But by now it's still a monocentric treatment here being done in Munich in my department. So this is the study. We'll publish this in 2018-19. You can look it up and you can just read it. And if you have any questions, just talk to me, phone me, and give me any back informations to tell me if you'd be also interested in workshops to learn this really great procedure. Thank you very much.